Hi, welcome to the second in a weekly series of In Conversation, interactive webinars with Chatham House Distinguished Fellow David Heymann. Each week from now on, we'll start with a conversation between David and I, exploring a specific issue. After that, the forum will be open to your questions on the latest developments and lingering questions. The theme we'll be discussing this week is testing. Just as a reminder, this briefing is on the record. Questions can be submitted throughout the session using the Q&A function. Please don't use the chat or the raise hands function, but the Q&A function on your Zoom box there. So I'm very pleased to have back with us today Professor David Heymann, who, as many of you know, is an uber expert on outbreak control. He also chairs the Strategic and Technical Advisory Group on Infectious Hazards, which is advising the WHO Emergencies Department on the response to this pandemic. Testing is a big topic of conversation right now in many places. There are lots of concerns about the low extent of testing going on in some countries, and we're hearing that there's a shortage of test components. The need for more aggressive testing is still a major thrust of the messages that the World Health Organization is trying to get across regarding what it's going to take to get us out of this. And it seems that countries that have embraced the WHO advice to test early are closer to normal life than those that are struggling to get on top of the testing aspect. And the situation that some countries are in now with testing rates and widespread community transmission raises so many questions. And there seem to be a few mysteries that hopefully David can shed light on. And by the way, because of the date today, I just want to let you know that he's not the type to pull an April Fool. So I'm sure that everything you hear is actually what he thinks. David, testing has always been a fundamental tool of disease detectives, hasn't it? I'm sure most of our audience are in no doubt that it's critical, but can you start by briefly summarizing why testing is so important for outbreak control and where it fits in, both in the initial containment phase and in the later phase that many countries are now in? And also, if you could address the difference between the role of the antigen tests, the one that tells you if someone has the infection, and the antibody test, that's the one that tells you whether someone has ever been infected with the virus in the past.
Yeah, well, thanks, Emma. And again, I will not put out any April Fools. I'll try to talk with what I know and what I hope is helpful to others. So to begin with, yes, there are two types of testing. There's a testing called PCR testing, which can determine, or ELISA testing also, to determine whether or not a person has the virus inside at the moment of testing. That test looks for nucleic acid of the virus, and it's a sure test that if someone is positive with PCR, they do have a COVID-19 disease. The other test is a test for antibody, and antibodies are developed early on during an infection and then remain after an infection for an indefinite period of time and may or may not be protecting people from future infections. So the two tests are determination of when someone is ill and at the same time when someone has had the disease in the past. Now the test to determine whether someone is ill is very important in outbreak containment activities. It can help people know when they should be hospitalized if they do have COVID. And also, it can tell the clinicians and the hospital staff that these people need to be isolated because they're infected with this virus, and the hospital workers have to take the proper measures. The testing is also useful for people who are contacts of known patients, because then if they are infected, they can be isolated and prevent future transmission patterns in the future. So that's the issue with in testing for acute infection. And in addition, testing can be used for health workers to assure them that they're not infected. It can be used on a regular basis, or it can be used once if a health worker thinks they might have been infected. So those are the uses of acute test: outbreak containment, isolation, diagnosis and isolation of patients, and in addition, testing of health workers and others who need to know if they're infected at a specific time. The other side of the coin is the antibody test, and these are useful for telling where infection has occurred in the past. So individuals tested can know that they've been infected, but a community that's tested can know what the status of immunity is, or at least of antibodies are in their community, and how widespread transmission of this virus has been in the community. Both have a role to play in dealing with the current pandemic. And there's no need to discuss which is more important, or to say countries aren't doing this and they should be doing this. Right now, we're all in this together, and we have to move forward together and understand what testing is for and do it to the best of the capacity of the country and based on the risk assessment that that country has made.
Yeah, I wanted to follow up on that actually now that you mentioned that. I mean, I must say, unless I'm missing something, I am a little bit confused about WHO's position on mass testing, acute testing, in terms of whether it's saying it's necessary for all countries. On the one hand, we have some very strong messages coming out of them that the lockdowns have bought us a second chance to go after the virus, and that this window has to be used appropriately, meaning aggressively find the virus and care for patients. I'm just going to quote, as a for instance, something Mike Ryan, who heads the WHO's emergency department, which is running the WHO response, said the day before yesterday. So if you could just bear with me on this one. This is what Mike said the day before yesterday. If countries are going to move away from shutdowns and lockdowns as a means of suppressing the virus, we have got to put in place the public health surveillance, the isolation, the quarantine, the case finding, the detection. We've got to be able to show that we can go after the virus, because lockdowns alone will not work. The essential difference between Wuhan and Europe is that even during the lockdown, they continue to look for cases, detect, contact tracing, isolate all cases, including mild cases, away from their families. If you get those cases out of the community quickly, they will expose even fewer people, and that's how you get ahead of an epidemic. At the moment, in parts of the world, due to lockdown, most of the transmission is happening in the household. Transmission has been taken off the streets and pushed back into family units. Now, we need to go and look in families to find the people who might be sick and remove them and isolate them in a safe and dignified manner. Transition from shutdowns and stay-at-home orders can only be made if we have the means to detect suspect cases, isolate confirmed cases, track contacts and follow up on the contact's health at all times, and isolate those contacts who become sick. Okay, so that seems to be saying that rigorous, systematic community testing is a must. But then when you look at the WHO laboratory testing strategy recommendations, an official document, that one says, and I'm quoting, testing must be rationalized in areas with community transmission and where testing capacity cannot meet needs. Priority should be given to the detection and protection of vulnerable patients and healthcare workers. So that seems to be an endorsement of the approach being taken in at least this country, the UK. Plus there were comments from WHO the day before yesterday that there is no one size fits all, and each country has a unique situation, resources, etc. Maybe that's not inconsistent, and what they're saying between the two pieces of advice is that rationalizing testing is okay when testing capacity cannot meet needs, but that all countries have to build the capacity. But basically, is that inconsistent? I mean, is it okay to blow off mass antigen testing, let the virus transmit in households and extract the really sick, rather than identify all cases and remove even the mild cases? I mean, would there be a material difference in the outcome in terms of controlling the outbreak and the length of time before a country can open up? I mean, is what Mike's describing really going to be necessary from where we are now? What do you think?
Thanks. Well, we meet with Mike twice a week by Zoom, our committee, and we meet with the people who are developing the testing as well. And those two statements are very much in synchronization. Mike is putting out what is the most ideal situation, and the testing people are putting out what is feasible within countries. They also, neither one of them, talk about what's the most important element of any outbreak control, and that is making sure that the population is empowered to not only protect themselves, but to protect others. And some countries have emphasized that more than others. In fact, the UK has emphasized this from the very beginning, that people need to physically distance, they need to stay away from social gatherings, that includes social distancing, and they need also to be washing hands regularly in case they've touched a surface where virus has contaminated that surface. And they need at the same time to be protecting others if they're sick by self-isolating and by wearing a mask if they're coughing or sneezing. good bottom-up approach to making sure that everyone is contributing to outbreak containment activities. If a population understands that, it may be that testing is less necessary. And this has been shown in places like Singapore, in South Korea, where there's a lot of testing, granted, but there's also the willingness of the population to work together to stop the outbreaks. And that's what's important, not just testing, but a whole series of measures. And countries decide those measures based on their understanding of their own populations and based on the feasibility of testing based on what they have available to them and where they want to put their resources. In China, China muted or transferred a whole series of health workers from hospitals outside Wuhan to the area of Wuhan. That decreased the capacity of those hospitals to take care of other patients in those areas. And that's important consideration as well. So in countries that are deciding on their testing strategies, they're also deciding on how they can best make sure that their hospitals function, both for persons who are infected and persons who are not infected but need medical care. This plays into the testing role in making sure that you're testing people with the symptoms and signs, which is what's done in the UK, to make sure that they're isolated properly.
So just to come back on that, are you saying that it may be okay to not be going for mass testing, that this drive and all the criticism that we need to get to mass testing, that it may not be appropriate for all countries? Are you saying that, you know, that's okay? May not be?
Mike Ryan is the world's #1 epidemiologist, and what he says is the truth as to what must be done to really actively contain this outbreak based on experience in China and other countries. But countries have to do their own risk assessments, and they have to make an understanding in their country of what's available, what's not available, and then they have to measure, or they have to make their policy based on their risk assessment and what the feasibility is of doing certain parts of the perfect strategy in their country. So every country is doing what it can. No country should really be criticized at this point. What we need to do is all work together to make sure that we can contribute our part in protecting ourselves and protecting others, while the government does other things that it does to ensure that the health systems are functioning properly.
I'm sure there'll be a lot of post-mortems later on whether strategy A or B was a good idea, or, you know, what happened in retrospect. But there is something else I don't understand about why we are where we are in some countries, including this one and the US with testing. When China locked down Hubei province, we were told that that was buying time for the rest of the world to prepare. We had about 2 months grace. WHO was telling everyone to get ready. And what we had to get ready to do was outbreak containment. And as you said, testing is a cornerstone of that, the case finding bit. But was 2 months not enough time to get ready when it comes to testing? I mean, the first genome sequence from Wuhan was shared with the world on the 12th of January, 11th of January unofficially. And that enabled scientists to get on with developing tests. And groups around the world began designing, testing, and publicly posting protocols really quickly after that. And WHO published the first test protocol, which basically is a recipe for making the test, online on the 17th of January from a German virologist who'd gotten started even before the sharing of the genome sequence. And then a Hong Kong virologist, Leo Poon, okay, whose team had identified SARS was coronavirus back in the day, also developed a test within 6 days of the genome being shared by China, and that protocol was also published by WHO. I think there's 7 protocols on the list now. And some countries did get on it early with testing. New Zealand got the German test kit early on, and around a month before it even had its first case, they were ready to do testing. Australia also bought in test kits from abroad before they had any test cases. But other countries have decided to go it alone and not take a protocol from the WHO list and just validate it, but decided to develop and validate their own tests. So what I'm wondering is, if testing ability is so urgent, why would they do that? Rather than validate one that already exists, at least to get started with, and then work on developing their own test after that. Why would some countries not do that?
Well, I don't know why some countries didn't. I assume that most countries did, and from my understanding, they did deal with individual outbreaks when they occurred. Germany was right, that had one of the first outbreaks in Europe, and they were right on top of it immediately. The UK had several outbreaks, and they were on top of them immediately, as they had been previously when MERS coronavirus was imported into the UK. It doesn't take a whole series of extraordinary tests to do this. PCR is a commonly understood procedure that can be done for any viral infection. So PCR was being done very early in the UK as outbreaks were being dealt with. But then what happened was Italy showed a new way of working, or a new way of not working, because Italy had been concentrating on outbreak containment and wasn't watching what was happening in its hospitals. And all of a sudden, the hospitals became overwhelmed with patients, and they weren't able to accommodate them all. They didn't have sufficient ventilators. They had a very high level of mortality occurring. And so countries then adapted their strategies to a strategy which was more aimed at making sure that there was not a surge of patients into hospitals, but rather that there could be a more balanced arrival of patients in hospital. And to do that, many countries developed a delay strategy, and among them was the United Kingdom, which has delayed a major surge, hopefully, by making sure that they're looking for patients immediately and creating a surge capacity outside their hospitals, for example, in London, in the Excel Center.
But can you not do that as well as continuing to test, as Mike said, despite the other measures you're taking? Why can they not do that and continue to test, which, you know, has been proven to be a cornerstone of outbreak management?
Well, countries make their own decisions. The WHO doesn't make those decisions. And I can't tell you what decisions were made in the UK or why they were made. But I assume, as in other countries, they were based on national risk assessment, national understanding of what some of the modelers were saying, and then moving ahead with a strategy that they felt was compatible with that. And I don't think we can criticize any country for using the evidence they have and developing their own strategies, understanding that there is a perfect strategy put out by WHO and an admittance within WHO that sometimes that strategy can't be met.
So how difficult would it be to increase testing capacity more quickly, assuming that this massive ramp up is necessary and what somebody wants to do? I mean, how hard is it and how long does it take to just crank out more tests, make more swabs, more reagents, primers, whatever's involved? Industry that doesn't already make these can't maybe drafted in. I mean, of course, testing capacity is not just about getting more test kits, but expanding the whole infrastructure needed to support testing, labs and lab equipment, lab technicians, people to collect the samples. So can you address how big a deal it would be for countries that have capacity issues and want to ramp up to repurpose academic research or other labs, throw up field labs like what's done in the Ebola outbreak, or co-opt veterinary labs? Apparently in Germany, half of the vet labs are doing COVID testing, and more countries are starting to mobilize their veterinary labs to do the testing. And what about speeding up regulatory approvals process so that more labs are allowed to process clinical samples, train up lab technicians to do PCR tests, more people to collect the samples? I mean, can we use community volunteers to go and collect samples, or do you have to use only qualified epidemiologists to do that boot leather epidemiology of knocking on doors and finding cases? So what's the low-hanging fruit for expanding testing capacity, and are those efforts really necessary, and when?
Countries are doing lots of different things to expand capacity. Some countries have delegated this to the private sector, and private sector is ramping up what's called high throughput analysis to be sure that they can do many PCR tests a day. Specimens are being collected sometimes at drive-in sites where people drive in, get a specimen taken, and then move off, drive off again, and that specimen is examined. There are all different ways of doing this, and it depends on what the country does mostly. But they can't do ramp-up testing, especially for antibodies, if they don't have a licensed test. And licensing is there to be sure that the test is a valid test, that it's a test that will give a high specificity, that it will be sure that it diagnoses what is present, and that it's also sensitive enough to pick up most infections. So it's not a simple issue of just developing a diagnostic test. It then needs to be shown to be effective. And in the case of antibody tests in the UK and other places, they need to be validated to be sure that they're not picking up other coronavirus antibodies, that they're only picking up those antibodies which come from the current COVID-19 causative agent. So it's not an easy process to say, yes, we'll ramp up testing. It's got to be ramped up in a way that it's valid and that there's a involvement of the sectors that can do it best. And sometimes it's government, sometimes it's private.
But how long does it take to validate a test? Is that a long process?
Well, the process involves, first of all, collecting a panel, what's called a panel of blood serum from many different persons and understanding what's in those panels. So the country that's most ahead or was most ahead in validating was Singapore, because they had antibody tests and they also had panels of bloods which they had collected during the SARS outbreak, which contained SARS coronavirus antibody and also antibody from other coronaviruses. And so they were able to use those panels to validate the test that they have, and their test is validated and being used safely.
But how long did it take? How long does it take to validate a test?
Singapore,
we're talking months or a week or?
It took about a month until they could get it validated. So it takes a while. The UK now has validated its tests in antibodies, and so have many other countries in Europe validated their tests, as the US has done. And so those tests are gradually coming out and will be available in the marketplace, in public sector, and private sector, and they'll add a new component to outbreak management.
Okay, this is my last question before I open it up to audience questions. All of this ramping up capacity stuff, I'm just wondering, wasn't all of this part of pandemic planning? I mean, it makes me wonder whether either all those desktop scenario exercises were any good or applicable to the situation, whether they did flag this stuff but haven't been followed, or what. I mean, why are we only now starting to mobilize to draft in other labs into the system to do the testing? Couldn't that have been discussed in advance as part of pandemic planning and then sprung into action? I mean, did bottlenecks in testing come up in pandemic planning exercises?
Absolutely. They come up in all pandemic planning exercises, not only a bottleneck in production, but in licensing and in development, a whole range of different areas. And the countries that did heed their exercises and the recommendations from them were mainly the countries that had major SARS outbreaks previously. And they were actually very well prepared compared to many other countries which did exercising, but didn't take to heed the recommendations that came from those exercises. It's what happens many times. Nobody can really imagine what will happen in the future, and now we're living it. And it's easy to, in hindsight, say, well, countries should have been better prepared, and we would hope that they will be the next time, but they weren't. And so now what's important is to move ahead and do the best we can with what is prepared and what isn't prepared, and pull together so we can deal with this pandemic. And as you said, Emma, there will be lots of opportunity once this pandemic is under control to go back and look and see what should have been done this time. And hopefully that will be done the next time. And I'm sure with the damage that this is doing to our societies and to the economies in our societies, increasing the gap between the rich and the poor will be very important in the future considerations of countries. And there likely will be much better preparedness at that time.
Thank you for that. Okay, I sadly am going to cede over to the audience questions. And the first one I'm going to ask you is from Haley Ott from CBS News. And this is about immunity. There has been talk of testing people to see if they have already had COVID-19, but what do we know about immunity after someone gets a disease and how long that immunity might actually last? That seems to have been coming up fairly recently. A lot of people are relying on, well, once we have the antibody tests, everybody who tests positive for antibodies, no problem, you can just, you know, go back to normal and resume your life. And you said, starting at the weekend, that, hang on, that's an assumption, not so fast. Why is that coming up now, and why do you think that's not a safe assumption?
Well, we know that antibodies from other coronavirus infections have a short-lived capability of providing immunity. And so if a person is carrying antibody to, say, coronavirus X, and they've had a cold and that's what's caused this antibody, they could next year have a cold from the same coronavirus X and not be protected. So we understand that antibody in many instances is not protecting for the long term. In fact, in vaccination, when you give a vaccine, sometimes you need to give a booster in 2 or 3 years to make sure that the antibodies remain high and active. But in coronavirus, the antibodies decrease in some coronaviruses. They decrease in effectiveness and they permit another infection of the same organism. We don't know yet in the new coronavirus that causes COVID-19 whether or not that coronavirus does cause long-lasting immunity, and therefore we can't make too many assumptions. It would be nice to say, if I have antibody, then I feel a little bit safer in going back into the public, and I think we would all do that. I would do that as well. But with the caveat that I don't understand exactly how long that immunity will last, and I must pay attention to what's going on in science to know that. But certainly a reinsertion strategy would say, yes, people who have antibody to this coronavirus could at least begin to work, possibly, depending on what a country feels its risk tolerance is. They could begin working properly back in society. And then as more evidence becomes available, we'll know what happens. Immunity, long-term lasting, or effective immunity is also important in the development of vaccines. And we need to make sure that when vaccines cause antibody, that antibody is also protective. And we don't know yet whether vaccines can be developed, and if they're developed and effective, if they can produce long-lasting immunity. So lots of questions still to answer. It's a new virus in humans, a new way of understanding has to be developed.
One of the most upvoted questions in the Q&A box here has to do with the Imperial College report suggesting that suppression measures are the most effective at reducing the surge demand for ICU beds, but it also suggests that the more effective these measures are, the greater the peak epidemic will be once these measures are relaxed. And the question, which is anonymous, they didn't give their name, with no sign of a COVID vaccine being available for the next 18 months, is this lockdown to be accepted as the new normal, or will countries have to impose a cyclical approach to suppression measures, such as when certain triggers for demand for ICU beds are met until a vaccine is developed? Similar to what we discussed last week, but
yeah, well,
you could answer that.
Yeah, thanks, Emma. Well, I think first of all, we shouldn't assume that there will be a vaccine. We should assume that we need to deal with this outbreak with what we have today. We have several tools at our disposition today, and we have new medicines, which are being, not new medicines, but medicines which have shown to be effective in the laboratory against the COVID-causing virus, which are being studied today in the UK and other countries. This is hydroxychloroquine and also remdesivir. Both of these are being studied today in the UK and in other countries to see if they are effective in treating infection, but they must be used early. There are also studies of antibody from people who have recovered. This antibody is being extracted from these people. This is being used in trials to see if it's effective in either preventing infection among contacts or modifying infection in such a way that it's less serious. And there are companies that are developing monoclonal antibodies to do the same. So there's lots of hope on the treatment side, not just waiting for a vaccine. And there's also a fundamental understanding that people are beginning to have that they must protect themselves and protect others. The basis of good way forward. A good way forward is if people understand how to protect themselves, washing hands, distancing from others, making sure not to go to public gatherings, and respecting the rules that are set out by governments and by others, and at the same time protecting others, especially the elderly, from being exposed to people when they're sick. Wearing a mask if you're coughing or sneezing in the household, but making sure that the elderly and those with comorbidities are very well protected. So we have a lot of tools at our disposition right now that we can be using to modify this outbreak while the government watches to see as it releases measures or as it transitions out of complete lockdown, to make sure that the indicators that they will be watching don't get passed so that they have to then lock down sectors. Governments will be very cautious in eliminating different bans on different sectors as they go forward, making sure that it's done in the right way.
This is a question from Dimitris Moniudis. Apologies if I've mispronounced that, Dimitris. What is the specific standard reassigning deaths to COVID-19? Is there a global standard on the way statistics are reported on deaths?
Yes, statistics are reported on deaths among those people who have a positive test and who have died. So if there's a death and it hasn't been shown to be infected PCR with COVID-causing virus, then that person was not a death from COVID. So COVID deaths require, in order to be reported, a positive diagnosis and a death. Very simple, and they're reported to WHO on a regular basis. Modelers take those and try to make estimates based on the number of deaths and a whole series of other variables, what might be going on in the community. And this is just modeling. This is just estimates of what might be going on. But nobody really will know what's going on in the communities until these antibody studies that are now beginning in the UK and other countries tell us where circulation of the virus has occurred. So deaths reported are purely deaths based on the number of people who die that were positive for COVID. That doesn't mean that all of the deaths that were COVID deaths were captured. It means only those were captured that had a test that proved that the COVID causing virus was present.
So more questions on testing. There's a couple here that I'm going to put together. One from Rob Ewers: what is the status on home testing kits available at retail for families? And I'd add there, are they a good idea? What's going on in terms of validating them, and how reliable would they be? And another question is about can a private test be bought? So I guess a kind of overall question on that is government provided tests, private tests. Is anybody managing this, or is it just a free-for-all? What is going on with testing? And another one is, why is Germany testing more than the UK? That's from Peter Schellink.
Okay, well, Germany is testing more than the UK because their risk assessment and their strategy is one of testing, making sure that they identify contacts who have been infected and isolating them. And that strategy has been followed as they've seen an increase in cases, and they're continuing to follow that strategy as best they can. And in the UK, the decision was made not to do that type of testing, but to spend more time testing people who are sick to see whether or not they need isolation in hospitals. And at the same time, the UK, as in other countries, is seeing that there are more rapid tests being developed. There are tests sometimes in the private sector that are available. And I'm sure that governments around the world are figuring out exactly how those testing, private testing, could contribute to overall understanding of outbreaks. And there will also be developing a policy on if you have a positive test, here's what's safe for you to do, here's what's not safe for you to do. So these are coming along, it's early. Remember, this is only 3 months into a major outbreak pandemic declared a month ago. So we're just now learning how to do all these things together. But I can say that there will be private sector testing, and there maybe is already. There will be antibody tests available that can be done, used in the home in the same manner that a pregnancy test can be used, and can tell a person whether they've been infected in the past, and possibly even some of the antibody tests could tell whether or not that antibody has been produced recently and you might still be infected. So all of these different things are coming up, but they can't just, people can't assimilate them all and use them without understanding what they're for. And that's why the government is so important to be putting out information about them. And I know all governments are doing that.
Here's a question actually that I meant to ask you at the beginning of our session, but I forgot. It's from Mark Nottingham. and that is, what do we know that we did not know last week? And that kind of speaks to my question, which was new scientific understanding in the last week since we last met for this session. I've had seasonality, the immunity question, which we've discussed, and there seems to be some more recognition of loss of taste and smell as a symptom. But am I right on that? But if you could let us know, what is, how has our scientific understanding progressed in the last week?
Well, it's progressing in many different ways. There's right now a debate about the usefulness of masks, because Hong Kong has provided some evidence that masks may be useful in protecting individuals from infection. It's not clear yet whether or not that's true, and WHO, the group that I work with, is debating that again with a group of experts from around the world tomorrow to understand really if there is a change in, if there is evidence that would call for a change in what WHO is recommending now for masks, which is that they don't really have a major role in protecting people from infection, but they do, except in health workers, where they also wear eye protection. And they also have a role in protecting others from coughs and sneezes of those who are sneezing if they're worn by the people who are sick. So that's one area there's more evidence coming from. Another area is about the transmissibility, or the virus shedding, we call it, of people who don't have symptoms, but maybe 1 or 2 days before the signs and symptoms developed. It seems that they may be shedding virus at that period of time, and it may be, if they're talking and spewing droplets around, they may be spewing the virus around. So there's study going on in that area. We also understand now that the virus can survive on plastic surfaces for maybe up to 72 hours, on other surfaces for less periods of time. But all this is information that's coming available and being published actually online in front of paywalls by medical journals. So we're seeing global access to new information, and it's all of our duties to be looking up the specific areas that are of interest to us if we want to find out what's going on.
Can I just pick up on the mask thing, because that's very interesting. There have been very strong messages from WHO and other experts saying not only do wearing a mask, walking around the street for the general public, not protect you, but they may also increase your risk of contracting the disease, and also that how that plays into shortages for healthcare workers. If the community are taking the masks, does that take away supplies from the NHS? So I wanted to ask, these studies on masks, what kind of masks are we talking about? Are we talking about those paper surgical masks that people are walking around with, or other types of masks? And what are the implications, if that is true, for supplies to essential healthcare workers if this takes off? And there's already such a run on masks, despite the official advice that they don't help and may be harmful, that what's that going to mean if it's shown that masks might help, as far as reserving it for the most important needs?
Well, WHO bases its recommendations on evidence that they're able to collect. And there's more evidence now available. Just as Mike Ryan, when he talks about the perfect outbreak control, you need the evidence to see what has worked and how you could be doing the perfect job in outbreak control. So the evidence coming in, and I have to say that yes, there is a risk when you take off a mask as well, because if you're wearing a mask to protect you, somebody coughs directly on you and your mask becomes contaminated. When you take it off and you touch the outside of the mask, you may pick up virus on your hands that, if you don't wash your hands, could spread to you yourself through touching your face, your mouth, your nose, or your eyes. So there are all kinds of difficulties in making recommendations for masks. But as the evidence becomes available, it seems that there will be a debate. Well, of course, there is one tomorrow at WHO. There's one in the US. There's one in many countries, trying to decide whether masks really do play a role at some point in the outbreak containment. And believe me, if they do, there's a private sector healthy enough in many countries to begin producing those masks in the quantities that are necessary. But masks improperly worn are not helpful either. And many people wear them over their mouth and not over their nose, or they put them over their nose and they don't push the clamps that make it adhere to the nose. Many different ways that people choose to wear masks. And then you might see them take them off to take a drink of coffee and put them back on. And that really does no good. If you put a mask on, you need to leave it on the full time that you're trying to protect yourself. So it becomes a very complicated issue, and one that WHO is working on and will be putting out evidence about soon.
Another most upvoted question, and this has to do with the apps that are the symptom tracker app. I think this is the King's College partnership, St. Thomas's app that allows people to report symptoms. The question is from John Paul Fitzgibbon. Months ago, the Chinese created an app that allowed for very quick and accurate tracking of the virus spread. It was announced yesterday that universities in the UK are creating a similar app. Maybe it's not the app I was talking about, but anyway. Do you think this is something the UK should adopt, bearing in mind that many people are conscious of sharing too much information?
Yes, in fact, many countries have developed apps that help them identify where cases might be, where contacts might be. Many are following up contacts through apps. There are all kinds of applications being developed to deal better with this outbreak. And of course, there are concerns about public and confidence and confidence and confidentiality. Governments need to be thinking this over and developing national policies on this, because this is a valuable tool in outbreak containment, and we need to be using the most cutting edge technologies today. So sharing of data, sharing of all kinds of data is very important in outbreak containment activities, and governments need to be looking at how they can facilitate this while making sure that individual protection of their identities is possible and contributing to a better control of an outbreak. So there are uses for these in the future. There's actually an article in Nature, or a letter from Rachel McKendry at UCL, which talks about this, and that's available online.
Here's a question from Hannah Devlin. I got advertised a £39 antibody test on Facebook yesterday, made by a reputable company, one that other countries' governments are using. Should I buy it? If not, why not?
Well, I think that's up to the person. If you buy it, what is the purpose of buying it? If you're buying it for your own interest in knowing if you have antibody, then why not buy it? But the problem is you don't know whether this is a highly specific or sensitive test unless you've read the package insert and unless you ask the company what is its sensitivity and specificity. So it's a free world. Anybody can buy what they want to buy and use it. But you need to think twice about whether it's a wise investment for the purposes that you want the test for. If you want it just to see if you have coronavirus antibody, then you could check it. If you want to see if you have COVID antibody, then you might need to do a little bit more detailed investigation of what that test really does tell you. So, you know, the best policy is to wait until you understand what the capacity of that test is before using it, but there's no restriction to buying the test and using it if people want to.
Time for a couple of more questions. Let's take this. It's from Rob Ewers again, but it is the most upvoted question at the moment. The UK death rate per case appears to be higher than other countries. Is this an issue of health service resourcing?
What it's an issue of is the amount of testing that's being done by countries. Some countries don't test all their patients, some countries do. And you know, what's reported to WHO, as I said earlier, is virus confirmed infections, but some countries may not be reporting that. Or if you look on the Johns Hopkins site, where many people are looking, they may have a different source of information, and it may not all be validated COVID deaths. So I can't make a judgment on what's happening in the UK as compared to other countries, because we aren't really 100% certain of what's being reported from those other countries. We do know that UK reports only confirmed deaths. And so that in itself is something to look at. And what we don't understand is the number of other infections in the countries to create a case fatality ratio which tells exactly the percentage of people who are dying from infection. We don't know that in the UK. We don't know that in any other country, because we don't know yet the full range of people who are infected and what their symptoms are being manifest as.
Thank you. Unfortunately, it's now 10:45, so I've been given strict instructions to end on time. There are still loads of outstanding questions, and I'm sorry to the audience, to those who didn't get a question answered or still have outstanding questions. So we're going to have to wrap it up now. And thank you again, David, for joining us, and look forward to our discussion next week.
Yeah, I think we can take some of these questions from today and go over them next week, because I think testing is a rapidly evolving field and people deserve to know what's occurring in this area. I know WHO is re-examining their policies as well, and maybe we could answer some of those questions again next week.
Well, what about, well, we could discuss this offline, but what about us answering them and posting that on our website for some of these unanswered questions?
Also very
Can you give me the time to do that?
Sure.
Can you spare a few more moments?
Sure, I'll be happy.
Okay, great. Thank you very much, everybody, for joining us, and hoping you can tune in next week, and I will see what can be done to get some of these outstanding questions answered.